Both the treadmill exercise test or TMT and Dobutamine stress echocardiography, known in short as DSE, serve to unmask coronary artery disease by inducing stress. But they do so through different mechanisms: physical exertion versus pharmacological stimulation. Let us have a comparative overview of the two tests. The primary mechanism, as mentioned, is physiological exercise, typically done using the Bruce protocol. Sometimes a modified Bruce protocol is also used. Then there are several other protocols which are rarely used. In pharmacological method, it is synthetic catecholamine, dobutamine, which is given for the stress, which increases the heart rate. Treadmill test is best for mobile patients with a normal baseline ECG. Persons unable to exercise, like those waiting for liver transplant, or with abnormal ECG, like those with a left bundle branch block, which makes interpretation of ST changes difficult, are better taken care of by dobutamine stress echocardiography. Sensitivity is about 65 to 70% for treadmill test, while it may be a little higher, 80 to 90% for dobutamine stress echocardiography. ST segment changes on ECG are the key indicators for ischemia in treadmill test, while it is regional wall motion abnormalities in dobutamine stress echo. Cost is much lower for treadmill test, while it is higher for dobutamine stress echocardiography. Here are some practical advice for the performing physician. A test is technically non-diagnostic if the person fails to reach 85% of their age predicted maximal heart rate, that is 220 minus age, also known as Astran's formula, unless ischemic changes appear earlier. Many ischemic changes occur during the recovery phase, so monitor the patient for at least 6 to 9 minutes after stopping exercise. A failure of systolic blood pressure to rise more than 10 millimeters of mercury or a drop in blood pressure during exercise is a red flag sign for severe multivessel disease or left main stenosis, producing left ventricular dysfunction also during exercise, so that blood pressure does not rise. During dobutamine stress echo, if the target heart rate isn't reached with dobutamine alone, adding small doses of atropine is standard practice to increase heart rate to the target limit. Warn the person that they will feel their heart thumping. Minor arrhythmias like premature ventricular complexes are common, but sustained ventricular tachycardia is a reason to stop immediately. Ensure that the endocardial border is visible in all segments. If not, you may have to use a myocardial contrast echo agent to improve visualization. That definitely will increase the cost significantly. Here are some common pitfalls which have to be avoided in a diagnostic test. Sometimes you may do a prognostic test ignoring some of these. Patients on beta blockers often cannot reach their target heart rate. Ideally, hold beta blockers for 24 to 48 hours before the test if the goal is diagnosis, not prognosis. But the primary physician who is taking care of the person should be consulted before withdrawing beta blockers, as withdrawing beta blockers increases heart rate and can rarely even precipitate myocardial infarction. Treadmill test has a higher false positive rate in women due to breast tissue interference or hormonal factors. If a woman has an intermediate pretest probability, a dobutamine stress echo or stress myocardial perfusion imaging, that is nuclear, is often more reliable than a standalone treadmill test. Treadmill is part of that, but that is interpreted based on the scan and not the ECG. You cannot interpret ST changes on a treadmill test if the person has a left bundle branch block or a pacemaker. Always check the baseline ECG If LBBB is present, skip treadmill test and go straight to Dobutamine stress echo or a vasodilator nuclear study, myocardial perfusion imaging. There could be some tricky cases. One is a mixed response, the biphasic response. This occurs when a heart wall segment initially gets better with increased contractility at low doses of dobutamine, but then worsens at high doses with regional wall motion abnormality. This is highly specific for viable but hibernating myocardium that is supplied by a stenotic coronary artery. It indicates the muscle is alive and will likely benefit from revascularization, either angioplasty with stenting or coronary artery bypass operation. If a person has 0.5 mm to 1 mm of ST depression or non-specific T wave changes, Duke treadmill score may be useful. Duke treadmill score is exercise time in minutes, from which 5 times the ST segment deviation in millimeters is subtracted, and again 4 times the angina index is also subtracted. So if the score is more than or equal to +5, it is a low risk, annual mortality less than 1%. Score -10 to +4, intermediate risk, requires further imaging like dobutamine stress echocardiography or nuclear scan. Score less than or equal to -11, high risk, consider direct referral for coronary angiography. So negative values are more significant than positive values. Angina index for the Duke treadmill score is calculated as follows. 0 points, no angina or chest pain during the test. 1 point, non-limiting angina occurs. The person feels discomfort, but it does not need stopping of the test. 2 points, limiting angina occurs. Pain is severe enough that the person stops exercise. There could be isolated septal dyssynchrony in persons with left bundle branch block or post-cardiac surgery patients, the so-called post-op septum, which move abnormally even without ischemia. You look for thickening, not just movement. If the wall thickens during stress, it is likely not ischemic, even if the movement looks paradoxical.